Hello, everyone. Good evening. I am Dr. Nupur Uppal, an assistant professor of medicine and also the director for cardiorenal services at North Shore University Hospital in New York. It's a great honor and pleasure for me to be able to present here, and I would like to thank Avatar 2021 for having me share my presentation today. So today we are going to talk about the cardiorenal syndrome, and the objectives of the talk would include reviewing the definition, pathogenesis, and evidence-based management strategies for acute kidney injury in cardiorenal syndrome, assess the fluid status of the patient and how to diagnose fluid overload correctly, and finally being able to establish a management algorithm to appropriately treat patients with cardiorenal syndrome. So the cardio-renal connection actually dates back to early 1900s when Sir Richard Bright was the first person to describe a relationship between the hemodynamics and how the heart and kidneys are linked. However, the initial attempt to actually have a terminology and classify cardiorenal syndromes was not made until early 2000s. The classification of cardiorenal syndrome, the most accepted one these days, is based on the Acute Dialysis Quality Initiative. And cardiorenal syndrome is an umbrella term which can be classified into 5 different types, with type 1 and type 2 being acute cardiac or a chronic cardiac condition leading on to a kidney injury. Type 3, type 4, respectively, mentions an underlying kidney disorder in the acute setting or chronic setting leading on to the cardiac disorder, respectively. And type 5 represents any systemic causes which can affect both kidneys and the heart, like systemic amyloidosis, diabetes, metabolic syndrome, and lead on to cardiorenal syndrome. So we will limit our talk to type 1 or acute kidney injury in the setting of acute heart failure, given the time constraints today. And the first question is to really know about pathogenesis of kidney failure in patients who have heart failure. The old school thought used to be that there is an inability to generate forward flow, which leads on to prerenal hypoperfusion, representing further an activation of RAS system, which activates your vasopressin, and further on leads on to fluid retention and worsening pump failure. However, this has not been represented in studies, and what actually studies have shown is a relationship of worsening renal function associated with an increase in CVP. Or in other words, the higher the central venous pressure is, the higher is the likelihood for somebody to have worsening of his kidney function. The thought process or the mechanics based on this pathogenic mechanism include presence of a high renal venous pressure, and as the renal perfusion pressure is the difference between renal arterial and renal venous pressure, the higher the renal venous pressure goes, there is definitely a decrease in the renal perfusion pressure, which can lead on to AKI. Besides these hemodynamic factors, which include decreased perfusion and increased venous pressure, there is also a lot of other factors involved in the pathogenesis, including humorally mediated damage via activation of sympathetic pathway, as well as RAS activation. There is also a lot of inflammatory and hormonal crosstalk leading on to neurohormonal pathways activation, which can also proceed to damage in the kidneys in the setting of acute decompensated heart failure. So coming to what is really needed to actually make diagnosis of somebody having acute cardiorenal syndrome, of course, history and physical exam is important as it helps in assessing the volume status of these patients. There is definitely discrepancies in lab parameters, which can indicate acute kidney injury, which can indicate fluid overload. Imaging modalities and invasive hemodynamics measurements are other things which can be used to assess volume status in these patients. So the first question is to know what is the best way to estimate your glomerular filtration rate in the setting of acute decompensated heart failure. We generally base the diagnosis of acute kidney injury on level of creatinine or a decrease in urine output. It's important to know that most of the big heart failure trials which have been done to date actually described acute kidney injury or AKI based on serum creatinine values. However, serum creatinine is really not the best marker to determine glomerular filtration rate in a patient with heart failure, as these patients might be cachectic. They may actually have lower muscle masses, lower creatinine levels. So it's really not the best marker. But to date, we still don't have the best marker to estimate GFR in these situations. There are certain other biomarkers which are now known, like cystatin C, which is freely will filtered as well as also reabsorbed as compared to serum creatinine. Plus, the muscle mass does not play a major role in the levels of cystatin C. It's still not the best marker. Definitely, there has been data suggestive of both serum NGAL and urine NGAL as predictors of acute tubular injury in patients with heart failure. And there is emerging data and emerging use of another parameter, another lab test called as NephroCheck, which includes testing for tissue inhibitor of metalloproteinase 2, as well as insulin-like growth factor binding protein 7, which helps in determining or predicting how likely is the acute kidney injury to happen in the setting of heart failure, or more so seen in post-CABG patients. Coming to the imaging modalities, we all know about the role of echocardiogram, role of IVC measurements. There has been some suggestion about bioimpedance vector analysis being used to determine the fluid status. But we'll just talk briefly about renal ultrasound as well as point of care of ultrasound for lung in these settings. So renal ultrasound does help us in distinguishing acuity from chronicity of the underlying kidney failure. But the other markers which can help us in determining whether the patient is volume overloaded or not based on renal ultrasound include measurement of intrarenal venous flow, which definitely has shown to have an association with increase in right atrial pressure when the flow pattern is discontinuous or monophasic. And also we can estimate renal venous stasis index. Again, the higher the renal venous stasis index is, the higher is the degree of congestion in these patients. Coming to the role of lung point of care ultrasound, we all are now familiar with the presence of B lines, which can be seen on a lung ultrasound, which do estimate that the patient has a lot of volume on them. But an important thing to know is that actually the appearance of B lines on a POCUS lung ultrasound can precede the development of symptoms in a patient. So very, very helpful in the acute setting, especially to determine if the patient is going into more volume overload and needs to be treated for that. The role of implantable hemodynamic devices like cardiomems has not been defined in patients who have baseline GFR of less than 60 or have underlying CKD, in other words. And also the role of measurement of pulmonary artery pressure using a catheter has not shown any benefit in terms of decreasing the incidence of AKI or having an effect on renal function. But sometimes we do need to take this route, especially in cases where it might be difficult to determine the underlying volume status just based on physical exam. So coming to the management of acute cardiorenal syndrome, the treatment goal is actually to achieve decongestion, which can be done either medically or with the use of therapies like ultrafiltration and renal replacement therapy. Diuretics are the key for medical management, and it's actually natriuresis, which will give you an idea of how good the patient is going to respond to diuretics. The question comes whether there is a difference between using high versus low dose of diuretic or between a bolus versus continuous usage of diuretic in these settings. There's actually no difference seen in trials when you're using an equivalent dose of diuretic as a bolus versus continuous drip. So either can be used to achieve decongestion. We also know about the concept of diuretic resistance, where the patient stops responding to the same dose of diuretic that he had been responding well to in the past. And there can be multiple reasons for diuretic resistance. So to overcome diuretic resistance, the first thing that can be done is the use of sequential diuretics, where you actually end up using a different type of diuretic, like a thiazide diuretic, a carbonic anhydrase inhibitor, an SGLT2 inhibitor, in addition to loop diuretic, to basically block different segments of the nephron and potentiate the effect of diuretics. But often you may end up having an increase in serum creatinine after using diuretics. So what do you do in that scenario? You really do not need to stop diuretics, especially if the patients are volume overloaded. And actually, there is now data to back up the fact that patients who had worsening renal function while on diuretics and actually achieved hemoconcentration had much, much better survival as compared to those where hemoconcentration or decongestion was not attained. Coming to the role of ultrafiltration, there are several potential mechanisms thought by which ultrafiltration can benefit patients who are volume overloaded. However, based on what we have as evidence so far, it has been seen that in most of the trials, there was no difference between medical therapy and ultrafiltration. And the CRRT heart failure trial actually showed a significant increase in serum creatinine and also a higher percentage of side effects in patients who were treated with ultrafiltration as opposed to pharmacological or medical therapy. Novel therapies include use of hypertonic saline. We generally end up using 3% saline. And the idea behind using the hypertonic saline is that it not only downregulates the neurohormonal pathways, it also gives a benefit in terms of maintaining or improving hemodynamics and also promotes natriuresis for these patients. Based on real life experience, there actually has been a lot of success seen with the use of hypertonic saline without compromising the respiratory status or increasing the underlying oxygen demands of these patients, where hypertonic saline is used in conjunction with diuretics. And definitely there has been an improvement in diuretic efficiency also noted with the use of hypertonic saline. There is also potential role of chloride being suggested, as it's now thought that low serum chloride might be a worse prognostic indicator as compared to low serum sodium level in patients with heart failure. It's also associated with poor diuretic response, and maybe giving these patients chloride might actually increase the tubuloglomerular feedback and decrease RAS activation, thereby leading to lesser sodium retention, lesser volume retention. So something to potentially think about, and maybe even a potential therapy in the coming times. So just telling you what we do here at our hospital, we start the volume overloaded patients with empiric loop diuretics, despite of what their underlying kidney function is. And we base our further decisions on the amount of urine output. If the urine output is not adequate, then we add another diuretic. And if it's still not adequate after addition of multiple diuretics, we consider adding hypertonic saline. Renal replacement therapy, there's really not much data to suggest if there is an optimal timing to introduce renal replacement therapy or whether it works better as compared to medical therapy. Just to summarize, cardiorenal syndrome represents a syndrome where acute heart failure, or more so in type 1 cardiorenal syndrome, can lead to an acute kidney injury. Initially, our goal to treat these patients is by achieving decongestion, which can be done with the use of medical therapy, mostly diuretics. And if that doesn't work, then we resort to more invasive means like renal replacement therapy. And eventually, our goal is to get these patients off of the renal replacement therapy and maintain euvolemia. Thank you.